I want to say one more thing.
Yeah.
I kind of hate the word resiliency.
Yeah, well, it's a buzzword.
Because it's
Many
become
ways.
a buzzword.
Yeah,
And
it
if you
really
look
has.
it up in the dictionary, it's a noun. So it's a thing. It's like, so very often in Native communities, it'll be like, oh, you all are so resilient, so we'll continue to throw terrible things at you. Just deal with it. You're Native people, you'll be resilient. I think about that, and as I think about that word for Native people, it's not a noun. It's a verb. It's an action. And that is what we see our resiliency as ongoing, continuing action. And that's how everybody should look at it.
That's right. We spend a tremendous amount of time collecting the dots. We need to spend just as much time in connecting those dots. And that's what Public Health Connects is all about. My name is Dr. Umair Shah. I'm the Secretary of Health for the great state of Washington. This is Public Health Connect. Hello, everyone, and welcome to Public Health Connects. My name is Dr. Umair Shah. I'm the Secretary of Health for the great state of Washington. Abigail's work is all about policy and institutional change to eliminate disparities for women of color, both locally here in Washington and across the country. Thank you so much for being here.
Thank you so much. I appreciate the opportunity to be here to share the experiences of myself and my community.
But tell us, first of all, a little bit of the audience about yourself and who you are. And
As an Indigenous person, I was raised in the heart of Alaska amongst the upper Otna Athabascan people, where my mom was adopted into a village with the matriarch of Katie John, Mentasta Lake Village. And I was raised in the strength of community. And what that meant, it was never about me as an individual or you as an individual, but how do we as an individual contribute to the strength of our community? That's what public health is. Indigenous peoples have been public health practitioners since time immemorial. It is who we are. And so I had that opportunity when I came to Washington. Came to Washington, soon found myself living in poverty. I was pregnant, and I went to a doctor's office where I was going for my first prenatal appointment, where I was treated terribly. That medical assistant saw my last name, Echo Hawk, saw that I had marked American Indian and Alaska Native, and spent 10 minutes questioning me about whether or not I had used alcohol. She at one point pushed up my sleeve, turned it over, and I realized that she was looking to see if I had been using needles in my arms. I was so traumatized by that, I don't even remember what happened when the physician came in. And as a direct result, I didn't access prenatal services until my second trimester, which is very dangerous.
Sure.
That's not what we want for our people. And then I discovered the Seattle Indian Health Board. My sister said, there's an Indian clinic in Seattle. And I walked in those doors as a pregnant teenager and received love, care, and worked with me to ensure I got health services, traditional Indian medicine services, and connection. I always say I was so blessed to be part of the SNAP program, to be part of the WIC program that is here in Washington State, that I was able to use to elevate my family and I out of poverty. And as a direct result of those experiences, I was able to go to college. I was able to get my undergraduate degree. I started being an advocate to ensure that women like me, people who birth, don't experience those things. About 7 years ago, I walked back into the Seattle Indian Health Board as the chief research officer, going back to the community that served me. And that's who I am, and that's who my parents raised me to be. How do we contribute to our community? And how do we ensure that we are undoing these institutional practices that judge a young Native woman and automatically assume that I'm an alcoholic or a drug user, instead of a young person who understood my responsibility to this beautiful child that was growing within me?
when exactly did you say, I want to change some of this? It wasn't when you walked into the Seattle Indian Health Board. It was well before that. But at what point did you feel, I've got power, I've got the ability, I've got talent, I've got the articulation, I've got the words and the spirit to be able to change something?
So a lot of what you're talking about, I didn't experience for a long time. I remember in high school, I took my guidance counselor after taking all the little tests about where you should go to college and all this. He's like, you'd be a perfect receptionist. And as I think about going to that school that was predominantly white, the other kids of color were receiving the same guidance. And so there's the assumptions made that I wasn't smart enough. And in fact, I actually thought I was really bad at math until I went to college and I was like, oh, I'm actually really good at this, and now direct a tribal epidemiology center and am changing the nation's way that we look at data and how to use and calculate data and numbers for American Indians and Alaska Natives. But those stigmas that exist, and sometimes when I walk into rooms, and we've had this discussion before, I'll walk into rooms and I have to prove why I'm supposed to be there.
Right.
So we're constantly having to prove ourselves, and that often creates within us what is called imposter syndrome. Sometimes it's like questioning, do I belong here? And what it was that really gave me the power, the strength, and the ability to speak was the community around me who told me, not only do you belong here, but we as a community are choosing you right now to be in this place, and we are going to support you. During 2020, as you're well aware, the epicenter of COVID-19 was Washington.
That's right.
We knew that it was going to disproportionately impact Native people. We knew we were going to be in a fight. And so the Seattle Indian Health Board, immediately as COVID-19 hit our communities, was in a sense just inundated with folks who were both infected, looking for testing, who were afraid, and we quickly ran out of PPE. We didn't have gowns, and in fact, our providers were changing their scrubs in between every single appointment because we didn't have the gowns that they needed. And then we didn't have enough places to wash them. The executive leadership team, including myself, were washing scrubs at night at our homes and then bringing them into the clinic the next day. I had a couple of physicians, because we were running out of surgical masks, who were sewing their own. So we put a call out to our state, our federal, and our county partners. We need PPE, we need masks, we need gowns, we need all of the things that are needed to keep our people safe. And so we finally receive a box. We're running low. I'm washing scrubs in my house at night, along with our executive leadership team. And when we opened the box, instead of PPE, no masks, no gowns, what we found instead were body bags. We had been sent body bags instead of the essential resources that we needed. I remember picking one up out of the box, and out of it dropped toe tags, dropped to the floor. And it just like hit me right here. They'll give us what we need to bury people, but not to ensure their life and vitality. And not only was I experiencing it literally for what was going on in our clinic right then, but also we could think about it as a metaphor for how the United States government has treated American Indians and Alaska Natives. The Indian healthcare system is chronically underfunded and is very rarely funded at more than 50% the need.
Right.
But they'll hand us what we need to bury them. I remember going home that first night and I cried the whole way. My house is about 15 minutes from my office. I cried all the way home, and I sat in my backyard for like 30 minutes because I also didn't want to traumatize my children. The next morning, we got to do it. Let's get to work. And we got to work as we had been doing before. And actually, the first shipment of PPE that we received after those body bags came from the community. That's public health at its best.
That is.
That's community stepping in and saying, okay, we're not going to get the resources you should be getting from your federal, state, and county partners. Instead, we're going to step in and use the resources that we have. And that's what Native communities have always done.
What did you do with the PPE that was supposed to come, but now you have body bags that have come in instead?
So Esther, our CEO, I went to her office not too long after. I was like, can I have that box of body bags? And she was like, what would you ever want with that?
Yeah, why do you want this?
Why do you want these? Because again, as a community health center, if somebody dies, we call an ambulance.
Sure,
We do
absolutely.
not, we would never use those. And so I told her, I said, I can't stand for what they sent us. I can't accept it for what it is. I was like, and so I'm an artist, I'm a poet. It's how I have used that artistic ability that exists within me that comes from my ancestors to deal with the trauma that we experience as public health practitioners and as a Native person. What we're talking about was a very traumatizing to me.
Sure. Yeah.
It was, I'm watching people die around me and they send me body bags instead of PPE.
Mm.
That was devastating to me. I was like, you know what, I'm going to take this stress and I'm going to repurpose it. I am going to change it into a symbol of resiliency and strength. And I did it for me, truthfully.
Sure.
I needed it because sometimes I couldn't see that strength and I couldn't feel that resiliency because I was surrounded by death.
Mm.
And so I took that and I turned it into what is a native ribbon dress, which is a type of traditional regalia. And from my teachings, that kind of traditional regalia holds in every ribbon the prayers of the people. And so I had it and I made it represent what I was experiencing. So, for example, on the sleeves, it's actually made of toe tags, those toe tags we were talking about. On the front of the dress are red handprints. And that's because I've been deeply involved in the movement to interrupt the cycle of violence that is missing and murdered Indigenous women and girls. And what we found during COVID-19 is that we saw rates of murder go up
Sure.
because folks were quarantined with their abusers. And so we saw more deaths, more murders of Indigenous women and girls. And so in those handprints, I remember doing it on my kitchen floor. I have it spread out on my kitchen floor and I'm putting red handprints on it. And my youngest son was there and he was helping me. And I told him, and I told his brother, my oldest son, I said, if I ever go missing, my fingerprints are here for you. I want to say one more thing.
Yeah.
I kind of hate the word resiliency.
Yeah, well, it's a buzzword.
Because it's
Many
become
ways.
a buzzword.
Yeah,
And
it
if you
really
look
has.
it up in the dictionary, it's a noun. So it's a thing. It's like, so very often in Native communities, it'd be like, oh, you all are so resilient, so we'll continue to throw terrible things at you, like body bags. You just deal with it. You're Native people, you'll be resilient. I think about that, and as I think about that word for Native people, it's not a noun. It's a verb. It's an action.
That's right.
And that is what our communities have always done, is take action. And that is what we see our resiliency as ongoing, continuing action. And that's how everybody should look at it.
That's right.
It shouldn't be something that, oh, these people are just resilient because we've continued to throw terrible things at them and they've dealt with it. No. Think about, how do I work in partnership with a community so I can build resiliency in the Department of Health and build resiliency in individual communities and take action together that builds forward the strength of a community.
There is really a reminder that the pandemic didn't start all of these inequities or all these problems or challenges. It just brought them to the forefront. You have worked over the years with women in particular, but families that have gone through trauma. Talk about that work and why it's so important to you.
Yeah. So I've been involved in doing everything I can to end violence against Indigenous women and girls since I've had the ability to step into those spaces. And that's because I do identify as an individual who has experienced sexual violence and physical violence. And I never want that to happen to my relatives. I never want my little nieces to experience the violence that I did. I have sat in circles of Indigenous women across the country where we've had conversations about what they do when their daughters are raped, because it's assumed it will happen, versus sitting in a conversation about something that may be rare, which happens in other communities. And in fact, I was a co-author on a study that talked to Native women in the city of Seattle, where we found of the more than 140 Native women we talked to, 94% of them had been sexually assaulted or coerced into sex in their lifetime. 94%.
94%.
Unacceptable. Unacceptable. The thing is when we put out this study, it was on the front page of Seattle Times, it was across the nation. People were so shocked. And I wasn't. I wish I was. I was not shocked at all. And no, neither was any other tribal nation in Seattle, in Washington, or in the nation, because we have been saying this for decades. And then all of these things amplify. So in our study, we found of the women who had been assaulted, they were, had very high rates of homelessness, substance misuse, suicidality, all of the things that we're working to combat every single day. But the root cause is the trauma. And we're not going to be successful in suicidality unless we're able to address the root cause. So that's why, as a public health person, I found it very important to kind of reach in and figure out where and what is missing, where are the gaps, where are the opportunities to actually have the data, so people can't say anymore, well, you have some stories, but you don't have the data. They don't believe us because the data isn't there, but then they won't fund us to get the data. Instead, we do it ourselves. Data for Indigenous people, by Indigenous people. And that is the action of our resiliency, because I refuse to let my sisters and my brothers suffer in silence.
Resilience really implies being action-oriented, to do something about it. But you also brought up something that's also interesting and also so critical in public health, but beyond, this real issue about data and telling stories. We oftentimes just do one or the other well.
Yeah.
Do you agree? I would assume you agree.
100% agree. And in fact, I see myself as a storyteller. My whole job is storytelling.
Yeah.
And it is telling the stories through the data and through the stories of the individual communities and individuals themselves. As an Indigenous person, I know that our stories and our numbers are absolutely essential and they must be told together. And when you do one or the other, and you're not incorporating both, you're not telling the holistic story. However, for Native people, the data, the numbers are very often not there. I actually put out a report during COVID-19 that I titled Data Genocide, very specifically related to COVID-19 and the fact that across the nation, people were not, including Washington State, were doing a terrible job on collecting the race and ethnicity of American Indians and Alaska Natives. And then those numbers and
We're
other
driving
numbers,
policy.
yes,
We're driving resource allocation.
it was used for the CARES Act allocation, the very first federal packages that put resources into communities, and they used bad numbers. And tribes did not get the resources they should, and people died as a direct result. So why is the collection of race and ethnicity so important? As Native people, our treaties that I talked about, our prepaid benefits, the resources we are supposed to get as a result of our treaties and the trust responsibility that the federal government has is based on numbers. So if census doesn't include us, if CMS data doesn't include us, if hospital data doesn't include us, then you have actually created the opportunity for them to say, oh, there's not that many Native people, we're only going to allocate this small amount of resources, when in fact there's way more than they want to acknowledge. And people die as a direct result. I see this as the current way to eliminate American Indians and Alaska Natives here in the United States. And these data systems are built in a way that makes us invisible. That is what I call data genocide. We have to be collecting race and ethnicity correctly in order to have the right data to tell the right stories. And then bringing in the voices of the community.
Yeah.
They are where the power lies.
What would success look like to you? Name it. 5 years from now, 10 years from now. What's your definition of a perfect world related to health?
What would it look like if we incorporated all the voices? And when I think about it from my community, the Indigenous knowledge systems that we bring integrated in every single part from policy, programming, and decision making, where we are valued. We don't walk in rooms where they question whether we're supposed to be there, but instead we are incorporated at every single step. Because I strongly believe that if we end health disparities, let's say we end cancer for Native people, we end homelessness for Native people, it would end it for everybody else. It isn't about just one people. When you work and you address that within one population, it reverberates across all populations.
Do you believe that in our lifetimes, or your children, my children, our next generation, will we be able to achieve that kind of future?
It took 500 years to build the disparities that exist right now, and it is going to take time to break them down. I have a little post-it note next to my desk that says, I sing songs for my children's children, because I know their future is going to be greater because of the work that you and I are doing, that everybody in the audience is doing.
Yeah.
And we have that opportunity to change in the life cycles of our children, of our grandchildren, of our great-great-grandchildren, to break down these systems of oppression and to realize true equity and justice. And it's going to take us some time to break it down. But I have hope every single day because I see the actions of my communities and the support that they bring for the work that I do, the work that you do, the work that everybody in public health is doing. And we have the standing and the support of tribal communities around us. And I know with that, I can do anything.
One of my favorite things about what you said is resilience is not passive. It's not a noun. It's a verb. It's action oriented.
This has been Public Health Connects. A reminder, this is a quarterly series. Please join us next quarter to hear more stories of equity, innovation, and engagement. Thank you, Abigail, for being here. Thank you to our audience. I'm Dr. Umair Shah. Again, until next time, signing off.